Okay, I see that people are joining now. Welcome. We're just going to give it a couple minutes so that everybody can filter in. Hi, everyone. We're just going to wait maybe one more minute to give everybody a chance to filter in. Thanks for your patience. We'll get started soon. Okay, go ahead and get started. Hi, I'm Stephen O'Connor. I chief the Suicide Prevention Research Program in the Division of Services and Intervention Research at the National Institute of Mental Health. We're pleased that you joined us today. We are hosting a webinar that's focused on timely and adaptive strategies to optimize suicide prevention interventions. I'd like to start with just a little bit of housekeeping. Participants have entered into listen-only mode, so their cameras are off and their mics are muted. There's closed captioning that's available for this webinar. You can use the Q&A pod to submit your questions at any point during the webinar, and we will do our best to address them. If you have any technical difficulties hearing or viewing the webinar, please note these in the Q&A box, and our technicians will work to fix the problem. You can also send a direct email to NIMH events at that web address right there, that email address. And this webinar is being recorded and will be archived on the NIMH website. So suicide prevention is an NIMH priority. The challenges and opportunities section of our strategic plan confronts the challenges that may lie ahead, and it describes some of the unique opportunities for scientific exploration to overcome these challenges and advance the understanding of mental illnesses. Suicide prevention remains a significant challenge and is addressed in this section and throughout the entire strategic plan. You can visit our NIMH suicide prevention webpage to learn more about current notices of funding opportunity announcement, webinars, workshops, and research highlights. We have a large suicide research team at NIH, and we are working hard to develop novel approaches and also implement evidence-based approaches into clinical and community-based practice settings. So researchers have demonstrated the effectiveness of interventions to reduce suicide risk, especially reducing new incidents of suicide attempts and intensity of suicidal thinking. This has been demonstrated in both adults and in youth. Simultaneously, technological advancements in assessment have improved our understanding of the nature and experience of suicide intensity, which is a much more fluid and dynamic process than was typically characterized in cross-sectional research designs in the past. There's now an opportunity to deliver more timely support in ways that match preferences and needs. Research in this area has the potential to enhance how well evidence-based strategies work and to better match those unique experiences and preferences of those who are receiving the services. This webinar will last for 2 hours, and it has 5 presentations and a moderated discussion. Today, we plan to cover these questions. which data sources are best equipped to inform intervention strategies, which intervention aspects should involve tailoring strategies versus simpler approaches, and then how such approaches can be incorporated into providers' workflows within a healthcare setting. Briefly, I'd just like to orient you to our extramural division structure at NIMH. We have several different divisions and centers, and these map onto different goals with the strategic plan and what the intent is of each of those goals. And when we think about moving the science from preclinical to efficacy testing to effectiveness testing in real-world clinical settings, we refer to the goals in the strategic plan, and the divisions largely are reflecting what those different priorities are. So the division that I'm in services and intervention research, a lot of times what we're trying to do is fund research that confirms the efficacy of an intervention strategy, and also testing out the effectiveness of something that's been proven to work, but placing it into the hands of providers in real-world settings, and also really understanding the factors that impact the implementation of those intervention strategies. We have a major emphasis on understanding how and why intervention strategies work, because it really helps us understand essentially what are the nuts and bolts of the intervention, how are they working to reduce risk, what types of factors are they changing within individuals, within families, sometimes also within healthcare systems or the providers. Having that type of model allows you to move the science forward, even if your intervention were not to be proven to be effective. It's still an important scientific contribution. And it also helps us understand disparities in care, helps us understand why interventions work for some people in some circumstances, but maybe not for others in other circumstances. So I'd encourage you to contact me if you'd like to discuss your research concepts. Can be reached at the email address there. So please feel free to reach out. Okay, I'm going to stop sharing. And I'd like to introduce our first presenter, Kate Bentley. She's at Mass General and Harvard Medical School. So Kate, take it away.
Hi, everyone. Thanks so much for having me here today and for that introduction, Stephen. We'll go ahead and dive right into an overview of just-in-time adaptive interventions to optimize suicide prevention interventions. So for my agenda today, I'll start by providing a rationale for why we might consider moving toward more timely and adaptive strategies to optimize suicide prevention interventions. I'll then turn specifically to an overview of the just-in-time adaptive intervention and micro-randomized trial. I'll then share an example pilot MRT that our team recently completed to inform a JITAI for suicide prevention. And then I'll end with a few key questions and challenges for the rest of the panel today. So I'll start with just a bit on the scope of the problem. We know that over 49,000 people die by suicide each year in the US, and the suicide rate has increased by over 1/3 in the past few decades, as shown here. In addition to suicide deaths, non-fatal suicidal thoughts and behaviors are prevalent. Recent data show that in the US each year, over 13 million adults have serious thoughts of suicide, just under 4 million make a suicide plan, and about 1.6 million make an attempt. Given this, we've fortunately seen a real proliferation of research that uses rigorous assessment methods to better understand and predict suicidal thoughts and behaviors in recent years. One such method that has truly exploded in suicide research is EMA, or ecological momentary assessment. EMA involves frequent self-report assessment of relevant affect and contextual states in one's natural environment and in real time. We've now not only seen countless different individual EMA studies of suicidal thoughts and behaviors, but also quite a growing number of systematic reviews and meta-analyses summarizing this body of work, showing just a few of those here. One of the main things that EMA studies have shown us is that suicidal thoughts are dynamic. Here's an example of this from a 2017 study led by Drs. Evan Kleiman and Matt Knock that shows the tremendous variation in suicidal thoughts over a 3-day monitoring period. In this figure, each participant's suicidal intent intensity ratings are, suicide ideation intensity ratings, are shown on a line. In this study, 94% of participants had a change over the course of hours in their suicidal thought ratings of more than 1 standard deviation, and over a quarter of people's ratings differed by at least 1 standard deviation from one survey to the next. Findings that are similar to this have now been replicated in other samples and by other research teams. We also know that suicidal thoughts and plans can escalate quite quickly to suicidal behavior. Just one example of this is a study from 2017 that was not EMA, led by Dr. Alex Milner, that found that roughly 2/3 of suicide planning steps happen within 12 hours of suicide attempt, and the median onset for most steps of suicide planning is within 6 hours of attempt. So overall, we've learned that suicidal thoughts and behaviors can vary quite rapidly over relatively short periods of time. A key question that follows from this is how we might think about optimizing our existing suicide prevention interventions to better match the highly dynamic and also heterogeneous nature of suicide risk. In a recent paper led by Daniel Coppersmith, we argued that there are 3 ways in which most existing evidence-based suicide prevention interventions may not be optimally matched to the dynamic and heterogeneous nature of suicide risk. First, timing. Most evidence-based interventions that we have involve contact with a provider in weekly sessions with little or no contact in between. This is not particularly well matched to how much we know that suicidal thoughts can fluctuate over hours, much less a week, and poses a real opportunity to improve the timing of our interventions and the frequency by striving to deliver interventions when and only when they're needed. And second, our existing interventions overall have relatively little systematic personalization or tailoring to a given person. They're pretty fixed across both people and time. This is especially relevant when we think about suicide risk, which we know is a problem that's very complex and heterogeneous across both people and times or contexts. Strategies that allow us to adapt intervention delivery in systematic and pre-specified ways based on data that are collected from individuals over time have the potential to maximize not only how effective, but also how efficient our interventions are. And last, many interventions for mental health problems and suicide risk specifically lack maximal accessibility. They can be difficult to find, costly, time-intensive, and fraught with barriers like stigma and hesitance to seek professional support. We know most people who think about suicide don't engage in formal treatment. Mobile devices offer us the opportunity to increase the reach of existing intervention strategies, including by offering people support based on changes in risk outside of planned session times with providers. The just-in-time adaptive intervention, or JITAI, is just one example of an intervention framework with the potential to optimize suicide prevention interventions in each of these areas. JITAIs are designed to provide the right amount and type of support at the right times. This model is very well suited to addressing conditions that escalate quickly during one's daily life. For example, things like stress, substance use, craving, and potentially suicidal thoughts and behaviors. JITAIs generally involve sending messages, reminders, or prompts through a mobile device in real time and in real-world settings. They're also timely. Intervention delivery is contingent on an individual's need and whether they're receptive to intervention at that moment. In a JITAI, tailoring variables are used, which can be collected using active measurement like EMA or passive sensor data, and these are used to make decisions about when interventions are sent. Along these lines, interventions are tailored to an individual's dynamically changing context and status over relatively short timescales, so minutes, hours, or days. And when discussing JITAIs, it's important to also touch on the micro-randomized trial, or MRT. This is an experimental design for building, evaluating, and optimizing JITAIs. MRTs involve sequential randomization, meaning that the same person can be randomized many different times over the course of a given trial. Randomization conditions can include whether or not an intervention is sent, but also what type of intervention is delivered. This means a couple key benefits. First, due to many points of within-person randomization, statistical power is maximized. And second, this can allow you to determine not only whether a given intervention is effective, but also which interventions work best in which contexts. And before I go on to some of our recent work in this area, I'd just like to make one more quick point. The JITAI is one type of adaptive and timely intervention design framework, and the MRT, just one type of experimental design for optimizing adaptive interventions. As I noted, the MRT is used to build and refine interventions that adapt at relatively fast timescales, so days, hours, or minutes. The well-known SMART design also allows for optimizing adaptive interventions, but involves adapting interventions based on changes observed over longer periods of time, like weeks or months. And then there's also the hybrid experimental design, which combines more than one design type, possibly an MRT and a SMART, in the same trial to test multiple different intervention components that adapt over multiple different timescales. Hybrid designs may especially have promise for suicide prevention, given that we know risk can fluctuate over both fast and slow timescales. I think we'll hear a bit more about these other designs later in the webinar. So for now, I just want to underscore that a range of different experimental designs exist for optimizing different types of adaptive interventions. So I'll now move on to a recent example MRT that we conducted in the area of suicide prevention. Our team, including Drs. Walter Dempsey and Matt Knock, who have joined us today, recently completed a pilot MRT to determine the feasibility and acceptability of one component of a larger JITAI. So most, if not everyone, on this webinar today is likely familiar with the evidence-based safety planning intervention. Recent work has shown us, though, that actual rates of safety plan use during psychiatric hospitalization, which is the highest risk known time for suicide, are relatively low. We've also learned that using evidence-based coping strategies to manage suicidal thoughts in the moment is associated with reduced proximal suicidal thinking and the risk of future suicidal behavior. This led us to wonder whether the JITAI framework could be leveraged to help promote safety plan use and effective coping during actual moments of elevated risk after hospitalization, therefore potentially enhancing the single encounter safety planning intervention. So in this trial, we enrolled 87 adults who were admitted to a psychiatric inpatient unit for suicide risk. Everyone developed a safety plan before they left the hospital. And then after discharge, they received 6 prompts on their smartphone each day to do brief EMA surveys for 28 days after discharge. And these surveys included the 2 questions you see here, current suicide urge and intent. And participants were paid $1 for each survey they did. We embedded this MRT, which was pre-registered, into a larger ongoing EMA study. So our decision rule in this MRT pilot was very simple. When people reported experiencing elevated suicide urge or intent on a survey, they were randomly assigned to either no intervention or intervention. And the intervention was simple. It consisted of a brief series of smartphone-based messages that provided specific recommendations of strategies for managing suicidal thoughts in the moment. There were 9 total interventions, each of which included either content from a person's own safety plan or general evidence-based coping strategies for suicidal urges. The specific types of strategies we recommended also varied. You can see just 2 examples of these messages here. They were quite straightforward and light touch. 30 minutes later, we sent people another very brief EMA to assess their coping strategy use since the previous survey, as well as suicide urge and intent, and they weren't paid for this follow-up. So what we found was about 82% of people completed the 28-day EMA and MRT period. About 5,700 surveys were done in total, which works out to just under a 50% response rate. About 9% of surveys were randomized. This was about just under 2/3 of participants being randomized at least once. And we had about an 81% response rate to the follow-up surveys. At the end of the study, people gave on average decently high scores on validated measures of intervention feasibility and also acceptability. And we also did in-depth qualitative interviews that complemented these findings, but I don't have time to present today. So we also looked at preliminary intervention efficacy. This was using an extension of generalized estimating equations that are designed to provide estimates of time-varying causal effects of the interventions. Our primary outcome was proximal coping strategy use, so within the hours after just-in-time intervention. Overall, we found that receiving any versus no intervention was associated with a positive, small, but significant effect on in-the-moment coping, as shown here. We also looked at intervention moderators and found that neither pre-randomization suicide urge or intent moderated efficacy. We did find, though, that personalized messages were more likely to be effective at promoting coping strategy use than general messages. And then last, we looked at change in suicide urge and intent as a secondary proximal outcome. And although these effects were in the desired directions, they weren't significant. So in terms of our next steps from this preliminary work, we're about to start a larger MRT that builds on our pilot. This upcoming project was funded last year as part of a larger NIMH P50 Center grant. So in this project, we'll be stratifying EMA surveys into high, medium or low, and no risk levels, and testing different forms of both automated and clinician-delivered just-in-time interventions. And ultimately, our hope is to combine a more optimized version of this JITAI with other forms of adaptive interventions to try to build a comprehensive and also scalable adjunctive approach to helping to reduce risk after psychiatric hospitalization. I'll now close very briefly with just a few key questions and challenges in this relatively new area of work, of which there are many. So one is, what are the optimal data streams, tailoring variables, and timescales to use when adapting these interventions? Indicators of risk or vulnerability that can be used as tailoring variables can be measured passively, actively, and over many different timescales and frequencies, each of which has trade-offs in terms of burden, engagement, and accuracy. And then also, what are the highest priority contexts and populations for suicide prevention JITAIs? I've shared some initial work by our group targeting the post-hospital period among adults. You'll hear a little later today about some very exciting work among young people, and also the potential to take these approaches outside of healthcare systems and into community settings. And third, how do we maximize engagement with JITAIs for suicide prevention? Even if we build something that is quite powerful, if people don't use it or don't engage with it, it's unlikely to be effective on a large scale. And then importantly, how and when do we approach integrating JITAIs within our existing healthcare systems? These, and there are many others that I hope we can dive into more a bit later. So in closing, just want to thank all of the amazing collaborators, several of whom are on here today, who worked on some of the project that I showed here today. Thank you very much. And now I am turning the stage over to Dr. Randy Auerbach.
Great. Thank you for a really wonderful introduction to this panel, and thank you for inviting me. My job in this panel is really to talk about a variety of different passive and active data collection strategies, and I'm going to focus on our work that has employed novel methods to improve the detection and treatment of depression and suicide among adolescents. And why this is important to start here is that the strength of our just-in-time interventions is contingent upon our ability to detect distress in real time. And The umbrella of real-time monitoring approaches is relatively broad. What I'm going to focus on, which Kate intimated in her in the previous presentation, is experience sampling methods. And these are active approaches to assessing how we're feeling and thinking and behaving. And generally, the tools of the trade in this context are ecological momentary assessment, which is really focused on what somebody is feeling here and now. And that's often compared to, say, daily or weekly monitoring, which is capturing broader swatches of time. So how are you feeling over the course of the day, or how are you feeling over the course of the week? In addition to these more active approaches, our group, in collaboration with Nick Allen, who's also here today, has focused on leveraging passive monitoring approaches. And with passive monitoring approaches, we have focused on smartphones, but others on this panel, including Eva Shiz, has notable papers on utilizing wearables. Using the smartphone, our group and others have focused on metrics around GPS, accelerometry, and keyboard inputs, in so much as these are metrics that we could then operationalize into psychological and behavioral phenomenology that is of interest to the outcomes, most notably here for depression and suicide. As I'll discuss throughout the course of the presentation, there are a wide range of issues to consider. And indeed, I think all of us could probably provide a presentation on the issues to consider. But briefly, what I'm going to be sharing with you today is that we think deeply about sampling rates, so how often we're going to assess, in the context of more active assessments, and how long we're actually going to follow these individuals. And context, of course, matters. Are we capturing the construct of interest? And I think that this is most notable when you're utilizing passive monitoring approaches. So you're collecting a real wealth of data, but can you actually operationalize these into constructs of interest, particularly as it relates to psychological phenomenon? And of course, one of the challenges, and this was highlighted in Kate's presentation alone, is this idea of missingness. And so what level of missingness can your study bear while also still addressing the core aims? And what level of missingness can you bear when you're thinking about smoothing the data in terms of denoising, in particular, passive sensing data? I'm going to be sharing a number of different approaches that we've taken. The details of these studies are not of particular import. I'm going to be providing you a bit of an overview, but kind of diving into why these are potentially good examples in terms of utilizing a wide range of strategies to start to detect distress in real time. And where I'm starting is in a study of high-risk suicidal youth. This was a study that was co-led by Nick Allen. It's a multi-site project where data collection was both at Columbia and the University of Pittsburgh with David Brent. And what I'm showing you here is the utilization of EMA to detect distress or capturing these real dynamic changes of affective states. And in this study, we followed adolescents for 6 months, and we had 4 one-week periods of EMA. And what I'm showing you in Figure A, what I think is really demonstrates this so well, is that this is just one subject's data. And this is capturing, on the y-axis, subjective stress ratings. And you're seeing that this individual has enormous variability over the course of, from moment to moment and day to day in terms of their subjective stress severity. And what's also interesting in this particular study is that we also captured context. And so what we're showing you here is, when they're alone in red, when they're with family in green, when they're with peers in orange. And then you could take these data in a really nuanced way and try to understand these fine-grained differences of how it's manifesting itself across these different groups. And here, I'm directly comparing our higher risk group shown here in pink. These are our ideators and attempters in pink relative to our psychiatric controls in blue. And what we're demonstrating in this figure is that in interpersonal context, these higher risk suicidal individuals are experiencing them as more subjectively stressful relative to their psychiatric control counterparts. Said differently, they're not really experiencing the benefit of being in interpersonal context in terms of mitigating distress. We also, and other groups have as well, successfully assessed using both daily and weekly monitoring of mood and suicidal thoughts and behaviors. This is a paper that was published a couple of years ago, in which, again, we're capturing daily mood, so daily mood ratings over the course of 6 months in our in groups that were very high risk, shown here in pink, to lower risk in blue. And we also had weekly assessments of suicidal thoughts and behaviors, and you could take these daily mood ratings and create weekly aggregates to understand what may be driving clinically significant ideation week to week over the course of the study. And it turns out that a 1 standard deviation drop in this weekly aggregates of mood led to a threefold greater risk in reporting clinically significant ideation. The level of ideation, which we considered clinically significant, because a licensed individual would follow up with a participant and conduct a suicide risk assessment, and when necessary, bridge to clinical care. So again, showing that you may know when to intervene based on both the daily and the weekly assessments. The other issue here, which I think is obvious in looking at this, that there's a variety of different patterns of missingness in terms of both the daily and daily mood ratings, but also the weekly suicide assessments. And this issue of missingness is something that I'm going to return to later in the presentation. If we're reasonably good at collecting active data, it begs the question, why should we go forth and collect passive sensing data? And I think for many of those who have utilized this approach, the answer is somewhat obvious, in that it provides less participant burden in the sense that you're just actively collecting this data in the background. It's highly scalable, whether you're collecting on a smartphone or a wearable. It's typically easy to employ. It has enormous temporal resolution, meaning you're capturing data within days, across weeks and months. And I think most notably, you're capturing these behavioral phenomenon outside the lab. Now, I want to be clear that even though it is more easily accessible in terms of capturing the data, it still requires enormous vigilance from the investigators. And I'm happy to address some of those questions if people in the audience may have questions about how to collect these data with good levels of retention. When utilizing the mobile sensing data, we've thought deeply as a group as to, can we ultimately begin to utilize some of these data to replace some of our active assessments? And this is a study that was led by Lillian Lee, an extremely talented investigator who works with our group. And one of her hypotheses is that what we write in our phone in a given day may be a reasonable proxy for how we're feeling in a given day. And so using the Ears smartphone app that was developed by Kasana, we're able to capture keyboard inputs from our participants. And what we did was we essentially extracted out all words. This is over the course of 3 months with 83 individuals using over 350,000 messages. And we could utilize Vader at the level of the message to extract out the sentiment of that message and then create an aggregate over the course of the day. And it turns out that more positive sentiment, as assessed through Vader, predicted next day mood, even controlling out for the prior day mood. Using latent Dirichlet allocation modeling, which is a type of factor analysis, you could also extract out topics. And so shown here in figure B, there are certain combinations of emoji that were also equivalently predictive of next day mood. And there's specific topics of words. So shown here in figures C and D, laughter related words were negatively correlated with depressive symptoms, where disagreement related words were positive related with dysphoric symptoms. You could also extract out other linguistic features. So in a separate study, this was led by Carter Funkhauser, we were interested in trying to understand, can we predict when a depressive episode was beginning to emerge? So here we looked at sentiment again using Vader, and this is over the course of 6 months using 1.2 million messages, or about 6.5 million words. We also focused on personal pronouns. There's a rich literature showing that greater proportional use of personal pronouns is associated with things like rumination. There's a rich literature about the use of personal pronouns in terms of suicide risk. And in so much as this was a study on depression, we were also interested in absolutist language, words like all or nothing that may capture cognitive rigidity. And it turns out, when looking at these weekly aggregates of these linguistic markers and mapping this onto weekly A-life ratings, so this is a timeline follow-back interview that would note when somebody was experiencing depressive episodes, that an increase in personal pronoun use over the course of a week relative to one's mean connoted about a 1.2 greater odds of likelihood of a depressive episode. We've also focused on looking at mobility metrics. So this is a study of high-risk suicidal adolescents, again, led by Nick Allen. And here we were really interested in understanding how mobility metrics may provide some degree of insight into suicide risk. And so in the context of the study, we knew exactly when a suicide event occurred. So for example, here shown an attempt or an emergency department visit. And what we can do analytically is that we can look at the 7-day period preceding this event and compare this to every other 7-day period for this individual over the course of the study. And it turns out that an increase in one's home stay over the course of in the prior week result in about a twofold greater likelihood that they would experience a suicide event in the subsequent week. We see that this effect holds when controlling for baseline ideation and other mobility metrics like entropy and average distance traveled. We're seeing that it's predictive of next week, but also holds true concurrently, so you could detect risk in the same week. Another issue that we and others in this panel and other researchers who do this type of work contend with is this idea of missingness. Missingness, of course, can conflate our capacity to identify distress states. And there's a really talented investigator in our group, Paul Bloom, who recently published a paper trying to understand whether there were sociodemographic or clinical factors that predict missingness, and also utilize the active weekly and daily prompts to determine what might be driving missingness within this study. And what we find is that there really aren't any sociodemographic and clinical factors that may be driving missingness with our active and passive sensitive features. But lo and behold, we're only getting about this 50% response rate with these individuals, these high-risk adolescents. And this is relative to about 70% of daily uploads for our mobile sensing data across both sites. And when you remove the individuals who provided less than 10% of the data, there's an uptick to about 80% of daily uploads for these individuals. And what's interesting about this paper is that Paul then sought to look to determine whether missingness in the data was related to subsequent clinical acuity, or whether clinical acuity, drove subsequent missingness both in active and the mobile sensing data. And what's phenomenal about this paper and the work that he did is that we're really not seeing in this sample that missingness was in any way related to clinical acuity. This is not to say that it's unimportant. It's just saying that it's not related to the missingness. And that's important for all the work that's going to be presented here today, because ultimately, these just-in-time interventions hinge on the fact that we can detect risk amongst our most clinically acute, because if we can't detect risk in our most clinically acute, we won't be able to deliver these interventions. So the question becomes, how can we leverage this information to improve treatment access? And most of the work that's going to be presented today focuses on just-in-time interventions. But Nick and I have been working on other studies where we're also trying to determine whether we could utilize this information just to enhance the delivery of routine clinical care. As you can imagine, active assessments and passive sensing can improve monitoring in between sessions. It tracks both symptoms and behaviors between these sessions. And because we now are starting to operationalize what may connote a distressed risk state, it provides opportune moments to deliver nudges at times when they may be able to utilize these skills. We recently started a randomized controlled trial among high-risk suicidal youth receiving intensive outpatient dialectical behavior therapy, and we're utilizing this Vera platform. And the data collection is just underway, but what's unique about this platform is that there's a clinician platform where they could look at aggregates of the geolocation, accelerometry, keyboard log, or weekly surveys, and they're provided in both daily and weekly arrays that are interpretable and accessible to the clinician. And this is paired with the patient's smartphone app, which is both collecting these data, but also is providing nudges. And these nudges are delivering the clinical skills that these individuals are learning in the context of their session. So the sessions are meant to really optimize skill acquisition. And these nudges could optimize the utilization, not just how to use it, but when to use it in the context of their distress states. We recently completed a randomized controlled trial in depressed young adults, and this was led by Lauren Weiner. And in this particular trial, we were leveraging behavioral activation, but what we found we compared a Vera plus a coach and a Vera self-care, is that there was remarkable retention. So about 73% of the Vera and the coach condition stayed in it for the 90-day treatment relative to 43% of the self-care. And what we're seeing is really promising results. And so in the context of this Vera trial, it's really leveraging these the passive sensing data to deliver nudges as to when to utilize these clinical strategies. And we're seeing reductions in both depressive symptoms and anxious symptoms relative to the self-care group. Just in closing, I want to leave with a message of promise. I do think that there is enormous promise. And as Kate intimated, I think that there are also challenges ahead in terms of determining the appropriate use case. When and where and how should we be deploying these types of strategies? The design is important. How long are we going to follow these individuals? What constructs have the validity that will allow us to dig in and really understand what's going on in the moment? And missingness, of course, does matter. These data are enormously challenging to work with in terms of making decisions about smoothing the data. Are the data sufficiently reliable when you're collecting mobile sensing data at the level of the feature over 1 day, 3 days, weeks? And once you start working with these data, you see the challenges that that arise. And then finally, although we would argue in our group that detecting risk is incredibly challenging, it's really only half the equation, meaning detecting risk will allow us to know when to intercede, but we also need to spend an equivalent amount of effort, if not more, in terms of developing strategies that actually engage an individual in a distressed state. In closing, I just want to thank my amazing team at Columbia and my collaborators around the country and the funding agencies that support this work. And with that, it gives me enormous pleasure to introduce Dr. Leslie Adams.
Thank you so much, Dr. Arabek, and hi, everyone. Thank you so much for attending. Today, I have the pleasure of talking about measuring social context associated with suicide intensity. I'll share my screen now. Here we go. All right. From here. Okay. So the social context that shapes suicide intensity, particularly my work focuses on marginalized populations, Black and Brown populations across the United States and abroad. And by social context, I'm referring to just broader environmental and societal factors. I'll talk about, poverty, social isolation, state-sanctioned and community violence, and also discrimination. These are the things that shape how people navigate their daily life, how people live, work, and play, and it also influences their mental health. And so again, these factors don't just affect people in isolation, but in the context of suicide prevention, it's really important to understand how we can capture this in real time and consider potential adaptive interventions to support these individuals in their most vulnerable moments. So just some quick, here we go. Unexplored factors related to social determinants and suicide prevention research. I just highlighted a few that I'll be touching on throughout this presentation. First is socioeconomic disparity. So where people live and are housed have a number of factors related to their employment, their underemployment, financial stress, which is a major risk factor for mental distress and suicide, neighborhood context, the exposure to community violence, the resources or lack thereof related to healthcare, education, and recreational and green space. And then everyday racial discrimination, which myself and my team works on specifically and focus on primarily. For today, I'll talk about the daily compounded instances of unfair experiences due to race, and that's considered everyday racial discrimination. It's important to think about and highlight these pieces because it does have an influence on mental well-being, suicide risk, and our potential areas of promise to leverage and focus on mitigating in a just-in-time adaptive intervention. So just to give a quick overview of two different aspects that shape social determinants of suicide for the population that I focus on, which are Black Americans. Residential segregation and ongoing poverty has left Black Americans with least desirable housing in the United States and some of the lowest resource communities in America. And so in addition to these high poverty rates, African Americans suffer from this concentration of poverty. So the figure on the left is from the Economic Policy Institute in 2012 that showed that nearly half of poor Black children live in neighborhoods with concentrated poverty compared to their counterparts in other racial and ethnic groups. This has since not really changed much. The poverty rate has gone down a bit for African Americans, but it still has maintained highest or higher than other groups, as we can see on the figure to the right from the Economic Policy Institute, ranging from 2013 to 2019, we still see that those overall rates are still high for Black Americans and for those under 18. And so when we're thinking about youth interventions for those in emerging adulthood and young adulthood, this is still a major, major area of concern and social context that shapes suicide for this group. Again, thinking about another major social determinant, which is employment and underemployment. From the Labor Bureau statistics, we know as of this year in 2024, Black men experience a 5.3% unemployment rate compared to their white counterparts. And this is the highest compared to Black women, of Hispanic individuals, both men and women. And so we're still seeing very high unemployment rates, particularly during the pandemic, but it has since, leveled and gotten a little bit lower. But when we're looking at it relatively, we still see that being much more heightened and higher. Also underemployment compared to their racial and ethnic counterparts. So that's the social context of the work that I have been working on, and that shapes the work that I'm about to present today. The major lingering questions that I have as I present our pilot work is just what can we do to enhance suicide and crisis interventions for those in these environments? And then how do these social determinants interact with factors such as proximal risk for suicide to exacerbate mental well-being and their outcomes. These are the major guiding questions of the work that I'm going to present today from our research team. This is called the GRACE research team. We are based in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health, and we broadly look at mental health disparities in Black communities. We focus on suicide prevention and understanding the nature of suicide among Black boys and men specifically, as it is a very underexplored area of focus in the suicide prevention world. We use a number of methods. So I'll show you some spatial epidemiology methods that my colleague Mia Campbell presented and worked on today. We also do community-based work, mixed methods and qualitative work, which I'll end on. And broadly, we look at the understanding of how racialized experiences and social context really shape suicide and mental health outcomes. So I'll present today on a pilot grant that we have since concluded. It was conducted during the pandemic in 2021, but it looks at how social context and particularly daily racialized stressors influence suicide risk among young adult Black men. Just to additional context, I always show the proportion of Black Americans that report, using a smartphone. A lot of questions I get in my work is this even a viable method for this population? And the answer is a resounding yes. Close to 83% as of 2018, I'm sure the percentage is even more now, of Black Americans report using a smartphone, according to the Pew Research Center. And so this highlights a major opportunity to work with Black Americans and this group to broaden accessibility to suicide prevention interventions. As a lot of people on this call and on this webinar know, a lot of our existing suicide prevention interventions are based in the healthcare system. There are less community-based interventions that have been shown to be effective or even applied in these populations. And so thinking about broadening the accessibility of just-in-time adaptive interventions outside of the healthcare community, where there still exists a number of racialized experiences and inadequate resources related to getting timely mental health care, this is incredibly important. Our inclusion criteria for this study was Black men ages 18 and up. We were targeting a young adult crowd of 18 to 35. It is a psychiatric sample primarily, although we did include snowball sampling, but that didn't yield many participants. But we had people that had received psychiatric care for self-injurious behavior, suicidal ideation, or an attempt with regular access to a smartphone. We did exclude folks with cognitive deficits and inactive psychosis just for the nature of the pilot aspects of the study. But I am imploring, many folks that are on this webinar and others to consider the inclusion of all of these populations because they are at most risk of suicide. This is just kind of an overview of our process. We did use ecological momentary assessment. So thank you to Drs. Bentley and Auerbach for giving a great overview of what ecological momentary assessment is. But we had them conduct a baseline survey and then followed them for just 7 days. Again, this is just a small snapshot of understanding what their suicide risk is. We had them conduct random prompts throughout the day and an end of day daily diary where we assessed their racial discrimination measure that I'll present in the next slide. We also had some passive data that we assessed, GPS and their accelerometer. And then we had an exit interview to see how well we did. And again, some of the promises and pitfalls of this method were yielded in our qualitative and our exit interviews that are now published. So broadly, we had about 10 participants that I'll talk about today. finished pieces of the study that I'll present. They range from 18 to 34. They were a range of sexual orientations, including bisexual, gay, straight, pansexual, and questioning. Different marital statuses, but most were single, 90% were single, half were employed, and then most of them did have their high school diploma or another higher level of education. And again, the aims of our study, in addition to did it work, is it feasible or acceptable, was what is the relationship between the geographic location where people are positioned and some mental health outcomes related to suicide. The data that we used in addition to our EMA surveys and the GPS data was overlaid onto census tract data from 2010 and also the 2015 Area Deprivation Index ranks. So to go through our findings really quickly, first on the left-hand side to orient you is the distribution of our ecological momentary assessment responses. This is Maryland, and in the center is Baltimore and Baltimore City. And so you can see the different responses for census tract, where the brighter red is higher responses, the lower and like orange and less I guess yellowish colors indicates like fewer responses. I would say, in addition to what Dr. Auerbach and Dr. Bentley mentioned, missingness is a major issue, especially in populations that have social context with high deprivation, and they have many other things going on in their lives than to complete this survey. So that is what's shown on the left-hand side. On our right-hand side, we've overlaid this with the 2015 Area Deprivation Index. So you can see the higher gradients green, the more green that it is, the more deprivation, which is an overlay of income, education, employment, and other factors related to socioeconomic status. These dots on the left-hand side are our PHQ-2 measure of feeling down, depressed, or hopeless. So you can see a lot of them are concentrated in the darker green areas of high deprivation, of feeling down, depressed, or hopeless more than half the days or several days, compared to not at all. But a lot of this is clustered in that high dark green area compared to other areas of Baltimore City and surrounding areas of Maryland. We also did a logistic regression to understand the associations between different proximal risk factors for suicide and where people are positioned in the time that they're completing their EMA survey. Belongingness, a sense of closeness to others, and feeling happier without me are three major proximal risk factors that people use to measure suicide risk, as opposed to asking, how are you feeling about suicide today? And so just quickly, I'll note that we had a varying ranges of responses, but the first one related to sense of belongingness among participants revealed that higher levels of deprivation were associated with lower odds of feeling of belongingness. So the more likely you are to be in an area of high deprivation, the more likely you are to say you don't belong and not feel belongingness. Closeness was a much more nuanced and complex relationship. We found that there weren't many significant associations found there between deprivation and closeness. However, once we incorporated some predictors, which I'll talk about in the next slide, we were able to see some significant predictors that interacted with closeness to inform their suicide risk. And then folks feeling happier without me. Initially, we were seeing that individuals residing in more deprived areas in the Area Deprivation Index were more likely to endorse that belief that people would feel happier without me. Some significant predictors that were found in this regression was home ownership. So in areas where there was high ownership, we were able to see mitigation of that negative relationship between belongingness and area deprivation. Such that individuals with living in higher rates of home ownerships were more likely to report a sense of belongingness. Same with thinking about closeness. Home ownership had a major factor there, but also racial composition. Areas where there were higher proportions of non-Hispanic white residents were associated with lower feelings of closeness. And then related to feeling happier without me, people with higher levels of home ownership and those who were younger were associated with lower odds of believing that people will feel happier without them. But again, this is interesting and gives us immediate, thoughts about how we can look at where people live, work, and play associated with their suicide risk. We again were focused on looking at social context, and for that we brought in the everyday discrimination scale. How does discrimination influence, this individual's belief of feeling close or feeling like they belong in this world that tethers them here? And so for this, we used the everyday discrimination scale. This is a widely used scale to look at subtle, more chronic forms of discrimination, and it captures day-to-day experiences. Here are 9 of the items that we assess in a binary way, yes or no, and this was assessed at the end of day. Here you can see, again, the map of Maryland and Baltimore City, but darker purple colors relate to a higher sum score, meaning they were reporting more instances of everyday racial discrimination versus white or light blue. And then overlaid with the area deprivation index, we can see that a lot of the areas where people were reporting high discrimination on a daily basis were also coinciding with areas of high area deprivation. Not always. You do see some areas like in this bottom corner, in the middle, where there's high everyday discrimination, but it's in a middle range area deprivation index. But you are starting to see some patterns here of how deprivation and discrimination may coincide and influence suicide risk. I want to close with a quote from one of our participants. Again, as part of our study, we gave them the opportunity to respondent-driven voice recordings of their daily environments. This participant said, "I'm about to leave the house and I always get real anxious about just leaving the house and having to get in my car and go anywhere." This person ended up spending a lot of time at home and wasn't, quite mobile in their everyday social context and environment. And the simple statement speaks to volumes about the everyday anxiety and stress that many folks face that stem from their social environment, their lack of safety in these surroundings. And it's really a reminder that these mental health challenges to capture aren't just static, but it really informs like how people navigate and move around their social environment. This person did not feel safe leaving their home, and so they decided to spend most of their time there. To end and bring it back just to the goal of today's talk on JITAIs and capturing social context, I also just want to quickly highlight some promises and pitfalls. A lot of these have already been stated, so I'll just go through them broadly. But the promise of these approaches and adaptive interventions is to get some real-time adaptive support when people are in high-stress moments. Again, if we're tracking this from an active standpoint where they have to respond versus passively, we get varying results and successes. But there is an opportunity there with JITAIs to leverage this. Context aware, again, leveraging what we know about the area deprivation index of areas of high social deprivation and disadvantage and areas of high racialized stress, we can think about when to deploy continuously tailored interventions. And again, this is a great scalable low-cost solution, especially for leveraging something everyone has, which is a smartphone, to think about delivering interventions in real time. The challenges from our experiences at the Grace Lab and from expanding this work is definitely the data quality. It's only as good as what we are receiving. And so the active aspects of data using EMA, missing this did indicate some aspects of poor mental mood, and we have that published in our most recent study. So sometimes non-response is a response, and we were trying to track that. Representation, again, this is for young adult Black men, it's a very small sample, but the challenges of recruitment, the challenges of retaining and enhancing engagement and trust and constant surveillance is something to be discussed and worked through as we continue to explore JITAIs. And again, the limited availability of contextually relevant intervention designs. There's a number of suicide prevention interventions out there. Again, a lot of them are centered in the healthcare system, but a lot of the community-based work and other work that I've been exploring as part of my research has not really focused on Black Americans specifically, of people that have been socially disadvantaged and may not have constant contact with the healthcare environment that can afford psychiatric care. So that's important to consider as we think about where we're funneling people to receive care when they're receiving, high stress. The takeaways is that we can leverage spatial patterns in JITAIs to inform areas of intervention. It is complex, so we do need to think about all the different inputs of demographics, of qualitative narratives, of understanding proximal suicide risks, such as social connectedness and happiness, not just our basic, suicide questionnaires of, are you feeling this way? Yes or no? What is the intensity on a scale? We have to think more broader about reasons for living, of other types of measures that people will feel comfortable answering so that we can get more detailed, granular data. I would just pause and end on acknowledging everyone that has participated in this work. I want to highlight Mia Campbell, who did all of the spatial epi work that I just presented today and will soon be on the market in the coming years. She's a graduate student, so I just want to note that. And with that, I will pass it off to Dr. Shawnee. Thank you so much.
Thank you, Leslie, for a great talk. All right. Hi, everybody. It's a pleasure to be here today. I'm going to start by thanking my amazing collaborators and also NIDA and NCI for funding this work. All the examples that I'm going to show you today are actually in the area of substance use, which is my main area of research. But in the next talk, Dr. Eva Sess will show you examples in the area of suicide prevention that are related to our joint work. So in the next 15 minutes, I'm going to talk about 5 common misconceptions related to JITAIs and digital interventions more broadly. And some of these were mentioned in the previous talks, but I'm going to elaborate on them. So let's start with the first misconception. And it is that JITAIs and adaptive interventions are the same. And to understand why this is a misconception, we first need to define the concept of adaptation. I know Kate already talked about this. But let's go over this again. Adaptation is formally defined as the use of dynamic information about the person to decide whether and how to intervene. And why do we need adaptation? We need adaptation because we want to be able to address not only the unique, but also the changing needs of people as they progress over time. Now, what we call standard adaptive interventions or just adaptive interventions, they are motivated to address conditions that change relatively slowly. And slowly means every few weeks or every few months. That's why the adaptation in standard adaptive interventions happens on a slow timescale. And these interventions, they typically guide the adaptation of human-delivered components because human-delivered components such as coaching sessions or therapy sessions, they can be adapted typically on a slow timescale. To make this concrete, and when I show you this example, this is an adaptive intervention for youth who visit the emergency department, loosely based on work by Maureen Walton. And the goal here is to reduce their substance use. This intervention starts with a single session in the emergency department, plus a digital intervention that delivers tailored messages on a daily basis. At week 4, they assess the participant's response status. If the participant self-reports to use drugs at week 4, they're classified as non-responders, and they transition to the second phase where they receive remote health coaching. This is human-delivered coaching. Otherwise, they're classified as responders, and they continue with the same initial intervention. So I want you to notice what's going on here. There's an adaptation process. It's a process where we use dynamic information about the person's response status at week 4 to decide whether or not to add coaching. And the adaptation process here happens on a slow timescale. It happens at week 4. It's because the goal is to address early signs of non-response to this minimal support, which is expected to unfold over 4 weeks. Now let's talk about JITAIs. JITAIs also include adaptation. They use dynamic information about the person to decide whether and how to intervene. But in JITAIs, the adaptation happens on a much faster time scale, every few days, hours, minutes, seconds. Why? Because the goal is to address conditions that change relatively fast. And these interventions, JITAIs, they typically guide the adaptation of digital components. Because with digital components, we have the capacity to adapt interventions on a fast time scale. As an example, I want you to think about the digital intervention from the previous example, okay? And suppose that as part of this digital intervention, every day we collect information about the person's state and context with EMAs and with sensors. And every day in the evening, if this combined information indicates that the person experiences high risk for next day substance use, we trigger a message with a protective behavioral strategy. Otherwise, we do nothing. So notice we adapt because we use information, dynamic information about the person's risk status to decide whether or not to send a message. But now the adaptation happens on a fast timescale every day. Why? Because the goal here is to address signs of risk for next day substance use, which are expected to unfold on a daily basis. So JITAIs and adaptive interventions, they're not the same. They both include adaptation, but the adaptation happens on different timescales. The second misconception is that a JITAI is an experimental design. And I'm really happy that Kate made the difference between an experimental design and an intervention design. So let's dive deep into the difference between these two concepts. An intervention design is the answer to the question, how should practitioners, therapists, coaches, the digital technology, how should they deliver the intervention in practice? What guidelines, what procedures they should follow? That's an intervention design. So what is an experimental design? An experimental design is the answer to the question, how should we investigators, how should we systematically manipulate independent variables so we can answer scientific questions that are of interest to us? In experimental designs, we have randomizations. Why? Because we want to be able to answer causal questions. In intervention designs, we have no randomizations because the goal is not to answer scientific questions. The goal is to guide the delivery of interventions in practice. And when you guide the delivery of intervention in practice, you're not randomizing, you're just giving practitioners a protocol. So if you look at the example adaptive intervention and JITAI that I showed you before, you'll see that there are no randomizations here, because these are intervention designs, not experimental designs. All right, the third misconception is that MRTs are always suitable for developing digital interventions. They're the gold standard for developing digital interventions. So why is this a misconception? It's a misconception because the design that we select should be guided by our scientific questions. For example, let's go back to the adaptive intervention that I showed you before. And suppose that in developing this adaptive intervention, me, the investigator, I have two scientific questions. One is how to initiate this adaptive intervention. You see here, the assumption is that I should start with this relatively minimal form of support. And maybe I should bring some coaching right off the bat. So would it be beneficial to start this intervention with or without coaching? The second question that I have is how to best address the needs of non-responders. You see the assumption here that I should step up with coaching for non-responders, but maybe it would be better to simply continue with the same initial intervention for non-responders. How do I answer these two questions? In this case, I'm not going to need the MRT. I'm going to need the SMART. So Kate already defined the SMART. In this case, what I'm going to do is randomize participants initially to the intervention with or without coaching. Why? Because I have a scientific question about how to initiate the intervention with or without coaching. And randomizations are here to help us answer scientific questions. So if I don't know, I randomize. And I also don't know what to do for non-responders at week 4. Either step up or continue. Because I have a scientific question, instead of stepping up for non-responders, I randomize non-responders at week 4 to either step up or continue, and responders continue with the initial intervention, because notice I don't have any scientific questions about what to do for responders. So I'm not randomizing them. If I had a scientific question about what to do for responders, I could have randomized them as well. But in this case, I don't. So I want you to notice how the randomizations are connected to my scientific questions, okay? And also notice that I'm randomizing here on a slow time scale, initially and at week 4. In SMARTs, we sequentially randomize on a slow time scale. It's because we're trying to answer scientific questions about how to best construct adaptive interventions in which the adaptation happens on a slow time scale. So I want you to notice the connection between how fast I want to adapt and how fast I need to randomize in the trial design to answer questions about how to construct that intervention. All right, so now let's go back to the JITAI that I showed you before. And suppose that here as well, I have 2 scientific questions that prevent me from developing a high quality JITAI. The first question is about the overall effectiveness of delivering a message with a protective behavioral strategy. I don't know if sending such a message will be indeed beneficial on average in reducing next-day substance use. And suppose that I also don't know under what conditions a message would be most beneficial. Here, the assumption is that I should trigger a message when risk is high, but maybe I should trigger a message when risk is moderate to high. I don't know. What I do know is that in this case, the MRT, the micro-randomized trial, can be useful. So what I can do is conduct an MRT where every day I still collect data about the person's state and context with EMAs and with sensors. But instead of triggering a message when risk is high, because I don't know if I should, I have scientific questions, I randomize to message versus no message. And I do this every day. So I'm randomizing sequentially, and that's what MRTs do. They allow you to randomize participants sequentially, rapidly, on a fast time scale. Every day in this case. It's because we're trying to answer questions about how to best construct a JITAI in which the adaptation happens on a fast time scale. So interestingly, these days, many investigators want to combine an adaptive intervention and a JITAI. And the reason they want to do this is because they want to integrate human-delivered and digital components. And these components are adapted on multiple timescales, slow and fast. In other words, they want to develop what we call multimodality or adaptive interventions, or sometimes we call them MADIs because we love acronyms. And anyway, to construct these multimodality adaptive interventions or MADIs, investigators face many scientific questions, especially about how well the human-delivered and the digital components work together. To answer these questions, they need a design that allows them to randomize participants sequentially to human-delivered components and to digital components on multiple timescales, slow and fast simultaneously. And that's what hybrid designs do for you. For example, this is a relatively simple hybrid design that combines the SMART that I showed you before with the MRT that I showed you before. So notice, at the same time that I'm randomizing on a slow timescale to the human-delivered components, every day I'm micro-randomizing participants to the digital components. So I'm randomizing on two timescales, slow and fast, because I want to develop an intervention in which human-delivered and digital components are integrated and adapted on multiple timescales, slow and fast. So the bottom line. To decide which design we should use, the first thing that we need to do is specify what kind of an intervention we want to develop. What is it? Is it an adaptive intervention? Is it a JITAI? Is it a MEDI or something else? And we need to specify our scientific questions. And then we need to let the scientific questions drive the design and not the other way around. All right, the fourth misconception is that JITAIs should always intervene or should be always motivated to intervene when people experience a state of vulnerability. And this is something that came up multiple times in the previous talks. So what is a state of vulnerability? It's a state of high risk for an adverse proximal outcome. And many investigators, myself included, we want to design interventions where we identify states of vulnerability when they happen in real life. And we intervene when people experience the state of vulnerability because we want to break the link between the state of vulnerability and the adverse proximal outcome. We want to prevent the adverse proximal outcome from happening. But what's the problem with that? The problem is that in many cases, participants may not be receptive to a mobile-based prompt, to a digital intervention when they experience a state of vulnerability. They may not be able to receive, process, and utilize the intervention that you're trying to deliver. The best example I can give you is from a study of smokers attempting to quit. This is Sense to Stop, led by Bonnie Spring. And in this study, what we found is that, this is a micro-randomized trial, by the way, we found that when smokers attempting to quit experience stress, sending a prompt to encourage them to engage in a stress management activity on the mobile device did not reduce the likelihood of experiencing stress. it increased the likelihood of experiencing stress in the next 2 hours compared to not sending a prompt. And we think that this has to do with people experiencing stress being cognitively overloaded. So when they're stressed, they're not receptive to the intervention, in which case the intervention can be more harmful than beneficial. So whether or not we should intervene when people experience a state of vulnerability is an open scientific question that we should investigate as opposed to make assumptions about. All right, the last misconception is that JITAIs always promote intervention engagement. And the reason this is a misconception is because it's not clear from the statement, engagement with what? In this manuscript, we define engagement as the extent that people invest energy in a specific stimulus or task. And when you define engagement in this way, you realize that to conceptualize and to measure engagement, we need to clearly specify what we're talking about. What are the stimuli and the tasks that we're talking about? The best example I can give you here is, again, in the area of smoking cessation. This is another MRT, different from Sense to Stop. This one is called MARS, the Mobile Assistance for Regulating Smoking, led by Dave Weather and his team at the Center for Hope at Utah. And in this case, we're trying to develop a JITAI that does the following, okay? This is for smokers attempting to quit after the quit date. Multiple times a day, we trigger 2 questions asking them about cigarette availability and negative affect. We use the answers to these questions to tailor a prompt that recommends that they engage in a brief self-regulatory activity. This is something they can do without the phone, like take a deep breath and count to 3, be mindful in the moment, take a short walk. And the goal is to get them to engage in this brief self-regulatory activity in the next hour as a way to regulate craving and stress. So I want you to notice what we're doing here. We are trying to promote engagement with a particular task, with the health behavior, the brief self-regulatory strategy. But to do that, we're actually expecting participants as part of the JITAI to engage in a task, complete the survey, and a stimulus, the prompt. Now, this is a very simple example. In many cases, you see JITAIs that include many tasks and stimuli that are interconnected that participants are expected to engage with in order to increase engagement with the health behavior. The point I'm trying to make here is that JITAIs can be designed to increase engagement in health behaviors. But to do that, we need to map out all the stimuli and tasks that the JITAI includes, and we need to make sure that they're designed, all these elements are designed in a way that is engaging. So to conclude, JITAIs have tons of potential. But to use them, we need to understand the boundary conditions. We need to understand when they're useful, when they're not useful. And we need to conduct research to optimize them. We need to conduct research to answer scientific questions about how to best construct JITAIs that are effective and resource efficient. And with that, I'm going to hand it over to Dr. Eva Sess.
All right, just give me 1 second to queue up my style. All right, okay, I think this is all set. Hi, everyone. I'm Eva Sess. I'm at the University of Michigan, and my job today will be to describe 3 studies as examples that illustrate how adaptive designs can be used to optimize brief interventions for individuals at risk for suicide in treatment settings. The 3 studies rely on different experimental designs, and I'm glad Dr. Nahum Shani and Dr. Bentley already covered this topic a bit. So the studies I'll describe will use a SMART or MRTs experimental designs to inform adaptive intervention. And the commonality between is that our aim is to enhance and extend standard of care and services that are used in healthcare settings. However, we do have different populations and slightly different settings. When describing each study, I'll try to highlight some of the considerations that went into the design, as well as some lessons learned. All right, I know there's quite a bit on this slide. I'll try to kind of walk us through it. This is a SMART study, and it focuses on psychiatrically hospitalized adolescents. Here, and this study is being conducted across 3 sites, so University of Michigan, Cincinnati Children's, and Henry Ford Health, and I want to acknowledge the site PIs who are involved in this work. Here, what we're doing is you can see from the very beginning, all youth are provided with a safety planning intervention. It's highlighted here in blue. This is happening during hospitalizations. And then teens are randomized to different intervention strategies delivered after discharge. First, half of the youth are initially randomized to daily supportive text messages. These are offered for the first 4 weeks after discharge. They're completely automated. And then we are tracking how the youth are doing with daily electronic check-ins. And this is the gray box showing monitoring. Using these daily check-ins, if you will, we're trying to determine whether youth are showing early signs of non-response, meaning they're showing signs that they might be moving towards a crisis based on a predefined threshold or a tailoring variable that we are deriving from the daily surveys. And we're doing this twice. So we're checking response status at the end of the first week. And then again, we are rechecking whether they're responders or non-responders at the end of the second week following discharge. For youth who are flagged as being non-responders and presumed to benefit from additional support, we are re-randomizing these teens to receive one of 2 augmentation strategies. So this is either booster phone calls with a counselor or asynchronous communication with a counselor using a web-based portal, which is similar to a patient portal. So it's supposed to sort of mimic the communication that's available in healthcare systems. Youth who are classified as responders, meaning they seem to be doing well within those first 2 weeks after discharge, we're not providing further interventions. And I wanted to sort of show how the SMART experimental design that you're seeing on the left is mapping onto the adaptive interventions, meaning treatment that Dr. Nahumshani sort of differentiated it to, how that's kind of corresponding to one another. You can see in this table that the SMART design includes 4 embedded adaptive interventions. So each starts with a safety plan intervention, and then includes different sequences of post-discharge support, depending on whether someone is a responder or non-responder. And our goal for this SMART trial is we're really interested in understanding what combination of supportive interventions following discharge are best, and also for whom. So I'd like to highlight just some considerations related to the SMART being carried out with a clinical population. So first, consistent with clinical care, as I mentioned, all youth receive a safety planning intervention. We're not really manipulating that at the very beginning, and that's because safety planning is considered standard of care. That's what they're actually receiving in a healthcare setting. And really, our scientific and clinical questions center more on optimizing post-discharge support, which is, as we know, often recommended, but not necessarily delivered or standardized in this setting. So that's what this particular SMART focuses on. It's the optimization of post-discharge support. Second, and this is really by design, the first line of post-discharge support begins with automated texting, which is a less resource-intensive approach. And it may be more feasible for healthcare system to implement for most youth if it turns out to be actually an effective strategy. We are reserving support that's more resource intensive for youth who are showing early signs of non-response, and those are in the form of a booster calls or asynchronous portal communication. Finally, I'd like to highlight that some of the challenges that could come up in a clinical setting has to do with technology itself, which many adaptive interventions and just-in-time adaptive interventions rely on. So for example, there may be specific permissions or specific requirements that are needed to use a technology supported intervention or software in a clinical setting. And in this study, we actually opted to use something that's more simple. So we opted to use text messaging and portal-like communication that can be very easily integrated in a healthcare setting, given that these are already being used routinely by healthcare system for things like appointments and reminders. However, in the case of a study, and this is still a research study, we're not actually relying on existing patient portals, for example, even though they are being used. And instead, to help us get a study off the ground, our team developed a customized platform that's used to deliver the portal, communication, and text-based intervention components. And if those prove to be effective and helpful, we can then easily integrate them into real-world practice. All right, so let me move to the second study. Here, this is a randomized controlled trial, and that has an embedded micro-randomized trial. Our goal is to pilot an intervention for parents of adolescents who are seeking emergency department services for suicide risk concerns. And the goal here is to learn about the feasibility, acceptability of the intervention, as well as study procedure, which includes the MRT procedures. Participants, which in this case are caregivers, parents, were randomized to a control group or to a 6-week texting intervention that was offered to parents, and that included 1 or 2 texting components. You can see that both intervention arms, and those are the 2 top boxes in blue, were comprised of a component where parents received something we're calling adolescent-centered text, and those were intended to encourage parental engagement in suicide prevention activities after discharge from the ED. Things like lethal means restriction, monitoring of suicide warning signs, providing support. And one of the intervention groups also included something we're calling parent-centered text, and those are highlighted here in green, where the intention was to improve parents' own well-being and stress level. And this component, this parent-centered component, included an MRT where parents were randomized twice daily, once in the morning and once in the evening, to receive or not receive a parent-centered text. The idea really here, which you can see in this figure on the right, is that we sort of conceptualized the parent-centered component that had the MRT specifically to optimize parent-directed support for caregivers with the intention to lower proximal stress, so stress occurring on a daily basis, improve their effective well-being, as a way to increase parents' capacity or ability to implement more effective support for the youth. So actually be able to implement some of these adolescent-centered recommendations, as we can kind of glean from different literature, but also probably your own life. When you're very stressed or not in a good mood, you're less likely to be receptive to implement recommendations or to do things maybe in a very effective way. So the idea is, if we can reduce parents' stress, and to understand sort of, when and how these prompts meant to improve parents' well-being should be delivered, we can ultimately help parents better support their youth, and that would be related to improving youth outcomes ultimately. So what about some design considerations? Well, first, and this is not just specific to adaptive or just-in-time adaptive interventions, but something that was very helpful for us when coming up with this design is obtaining significant input from parent stakeholders, as well as providers and suicide prevention experts. And actually, we originally were not planning to incorporate an intervention component that focused on parents' own well-being. This came directly from parent feedback and parents feeling like this is an important focus of the intervention. So we ended up adding this component following input from parents themselves. Caregivers were also involved in vetting the content. So in this case, literally each message in this intervention was vetted by parents themselves. And I would just emphasize how critical stakeholder engagement can be in shaping the intervention from the beginning, which again is not just specific to adaptive or just-in-time adaptive interventions. Another important consideration that I would like to highlight for this study is that has to do with intervention sustainability and extent of personalization. So regarding sustainability, many of you know that EDs are already quite busy, serving high volumes of pediatric patients who are coming in with suicide risk concerns. And for this reason, for this parent-facing intervention, we designed it so that it could be fully automated. And we're using texting, given that it's a relatively accessible, relatively low cost, and can be quite scalable if it in fact proves to be an effective strategy. With regard to tailoring and informing a future just-in-time adaptive intervention, we decided to embed this MRT again in the component that's focusing on parental well-being, given that we conceptualize parental stress as something that's more variable, and ultimately linked with parents' capacity to act on or implement some of these recommendations that we're providing as part of the adolescent-centered messages. And here there were some choices about how rapidly, how frequently should parent-directed support be adapted. We ultimately decided on 2 segments of the day when parents are more likely to interact with their youth. So we decided to do this in the morning and the evening. However, truthfully, the extent to which timing and frequency of tailoring and how much is indicated or really necessary is an important issue for any context or for any population. And that brings me to the very last study that I'm going to describe today. This is a pilot RCT that I'm co-leading with Dr. Adam Horowitz, who's a really close collaborator and a fellow faculty member at the University of Michigan. This pilot focuses on adults, unlike the 2 prior studies, adults at risk for suicide who are seeking emergency department services. This intervention combines safety planning, again, standard of care approach. It is used for individuals at risk of suicide who are discharged from EDs. This component will be delivered in an electronic format in the ED to ease the distribution of that safety plan. And it will be combined with a text-based support program that's provided across 4 weeks following discharge. You'll see that the MRT portion is highlighted here in this sort of like orangey yellowish color. And the idea here is that we are delivering the text-based support program up to twice daily. And here we're trying to understand how much should we personalize prompts that focus on coping and safety plan use. We're using different levels of personalization based on the initial electronic safety plan that was completed in the emergency department, and also dynamic personalized feedback that is referencing participants' recent functioning, reported via surveys that we're also collecting at the same time. Our goal here is to utilize the MRT to really explicitly answer the question regarding not only whether and when messages can be beneficial, but also what type of message with regard to degree of personalization and how those can impact functioning in day-to-day context, but also suicide-related outcomes. So in terms of some considerations for this setting, which can be baked into the experimental design, sort of the way that Dr. Horowitz and I are doing with this MRT is, and this is something that I think both Dr. Nahum-Shani and Dr. Bentley already alluded to, is really how complex the adaptive intervention or just-in-time adaptive intervention should be. More highly personalized interventions ultimately do require more effort from people who are receiving them because they have to respond to maybe more frequent prompts, but also from a health system perspective because more complex interventions require more effort to develop, to program, and also to maintain. So it may be that more simpler messages or interventions could be as beneficial or as effective, or maybe that truly for suicide risk concerns, we really need to be very complex and have very complicated interventions. So that is really an open question, and that's something that can be baked into the design. I've previously highlighted the importance of obtaining feedback from relevant stakeholders, and related to this issue is how the adaptive or just-in-time adaptive interventions might fit within the existing workflow in a healthcare setting. For example, the electronic safety plan and the texting program I described would ideally be seamlessly integrated within the current infrastructure in the ED and be connected to medical charts. For example, we've started having these discussions with information technology stakeholders in our health system to learn how this could be supported. However, at the phase of this project, which is a 3-year pilot, we don't have enough time to make this happen necessarily. And so we're working on developing customized intervention platforms for these intervention components that can have the right features and the right elements that will facilitate their eventual integration if and when they prove to be helpful. So in other words, sometimes we need kind of workarounds that are necessary to carry out the study while informing plans for future integration. All right, I'm going to zoom through this quickly. And to summarize, and this has been echoed in others' presentations as well, it's really critical to consider how the experimental design we're thinking about, whether it's a SMART or MRT or hybrid design, how that fits the scientific questions and the clinical issues for a given clinical population or setting. For example, what makes sense practically, clinically, with regard to the timing, the frequency of adaptations, how rapidly, not just can, but should these interventions be tailored for a given population, and also what intervention options are suitable for a given context. Second, we may encounter practical challenges in developing and evaluating adaptive interventions or just-in-time adaptive interventions that rely on use of technology in a clinical setting. I've mentioned this with the last couple of studies. It may be helpful to think ahead about how a given digital tool or software may fit or be approved for use within a healthcare setting. In some cases, we have to be prepared that integrating a new tool or new software can take some time. And there are many layers of approval that we have to be ready to work through. In addition, may be helpful and necessary, in fact, to work with information technology experts and decision makers in this space so that we can learn about technical limitations, technical requirements that are needed to eventually embed the technology that's needed to deliver adaptive or just-in-time adaptive interventions in these real-world clinical settings. And finally, just wanted to echo what's been said in previous presentations as well, is that it's important to partner with stakeholders in clinical settings, from patients to providers to decision makers, to help us carefully vet the interventions we're developing or evaluating, the various processes, as well as our assumptions of how something might work in a clinical setting to ultimately problem solve around challenges and eventually develop more impactful interventions. And just wanted to give a shout out to the many collaborators who are involved in this work, as well as research funding that's helping these studies keep going. Thank you so much.
All right. Hello, everyone. I'm Mary Rooney, Associate Director for Prevention Research here at NIMH, and I'm going to be moderating a discussion this afternoon with some of 4 discussions that we have here today. And I just want to start off by thanking everyone, each of our presenters here this afternoon, for such outstanding presentations, very engaging, interesting, thought-provoking, and really couldn't ask for more. So thank you so much. And I'll just introduce our presenters here to start off. Their bios are available on the webinar, Eventbrite webinar page, so you can go there and check that out for more information. But with us today, we have Matt Knock from Harvard University, Evan Kleinman from Rutgers University, Nick Allen from University of Oregon, and Walter Dempsey from University of Michigan. Welcome, everyone. So I wanted to kind of start off with a question related to something that came up in the Q&A. It kind of also builds off of the last presentation that we just heard, and it's related to different contexts that might be appropriate for just-in-time adaptive interventions. Like people come up with wraparound services for youth, or any services that include a 24/7 crisis line or intervention component. And so while, this intervention research is really still in the relatively early stages, I think it would be helpful to hear, what you all see as some of the hurdles that we need to overcome in order to embed these interventions in real world practice and community settings. And also, what are some things we can do to design our studies now, even in these earlier stages, to like proactively address some of these challenges and hopefully minimize like a research practice gap in the future. Go ahead, Matt.
Just jump in.
Yeah.
Great. Thanks for the question. I think these approaches are remarkably appropriate for a really wide range of contexts. And I appreciate that you asked some of the older folks here to be the discussants rather than the presenters. And the benefit of that is we've been around for a little bit longer and know that for decades, the interventions that have been available for suicide are weekly or monthly meetings with people. And we know that suicidal thoughts and suicide risk doesn't wait for those timelines. And so now we've got information on people at all the in-between times, and we've got the ability to intervene at those times as well. And that's relevant for outpatient care. It's relevant for inpatient care, for residential care, for wraparound services. Suicidal thoughts and risk is ebbing and flowing constantly, from smartphone monitoring studies. And so I think really important to have this kind of coverage for a range of contexts. In terms of challenges, and I'll spend 30 seconds and then pass it on. We need the kind of research that NIMH has been funding, and I think we need a lot more of it, and we need larger studies. Suicide, if suicide attempts what we're trying to predict, it's still a pretty rare outcome. 10% of people who pass through in a psychiatric emergency stay in the next month, 20% in the next 6 months. So to have enough events to predict and intervene, we need samples in the hundreds or in the thousands. So having results on large samples that replicate is going to be really important for scaling these things, especially given the type of outcome we're trying to predict. It's so important to get this right. So we want to make sure we've got really good data on prediction and intervention. Over.
Great, Nick.
Yeah. As you know, I'm very excited about this work and have been collaborating in it. But I also, as part of my role, we do a lot of user-centered design work with clinicians and with business gatekeepers in healthcare services. And one of the things that we're very regularly hearing from clinicians is that there is a real tension here between wanting to know more about someone's risk status and being very concerned that knowing more about that risk status will put you in a position where you have actionable information that you're not able to act on at that time. And that has both implications for clinical care, but also medical legal implications as well. And so this concept of, some people have used the term ubiquitous liability, the idea that if you're collecting continuous data or intensive longitudinal data in some way on someone's status, and if that data may have some implications for their risk, and then you are a clinician who is caring for that person, what are your responsibilities for responding to those data, and in what time period? And so we really often need to think about, there are different contexts where sometimes this can be well managed because there is some wraparound services, some 24-hour services that can manage that, but there are many, many others that can't. For example, something like 75% of behavioral health clinicians in the community work in practices of 4 people or less. And for those kinds of services, the ability to have that wraparound care is really not practical. So I think that as we develop these very important methodologies and all the exciting work we've seen today, we also need to be thinking about how are we going to ultimately implement them in ways that are acceptable, not only to patients, but also to clinicians and to healthcare services in ways that manage those risks.
Yeah, and Evan?
Yeah, I guess I agree with what everyone said so far. I think the thing that I'll add too is really taking a lot into consideration of who's going to pay for this stuff once the study's over. I think, we oftentimes think about implementation as a problem for like whatever the third step is, like towards the end. And that's true in many ways, but a lot of times we need to also think from the beginning, like, is this thing we're doing, like if it works out, we have this final product, like, will this actually work in our current healthcare system? Which of course we should probably change, but that's not necessarily something in our, sphere of influence. So really figuring out from the beginning, designing an intervention that, if successful, could be implemented in this way that doesn't cost money, or this way that, if it does cost money, will actually be revenue generating, thing like that. It feels icky as researchers to think about that, but it's sort of the reality of how we can implement this stuff.
Mm-hmm.
I'll just add one final thing, because I know we have more questions. I think one of the things I know we've been focused on implementation, when I see a lot of just-in-time adaptive interventions that are effective, they're often effective for a particular population. But then you might move to a different population and they may not be as effective. And I think a lot more work on how to adapt and transport those JITAIs to other populations is something that's missing. And then as the statistician of the four of us, I guess I'll say one thing on the more statistical implementation technical side, which is a lot of people get very excited about the desire to use machine learning algorithms to exactly know when people are at risk, and then use machine learning algorithms to figure out exactly what treatment to provide when they're in those moments. And the robustness and sensitivity and sort of baked in potential issues with those algorithms sort of sometimes go under the radar, both just from a system design standpoint of, can the system actually handle all of that? And also on the other side is, what are sort of the baked in equities that might be coming from using these ML predictive and ML treatment rules, as opposed to having humans in the loop?
Yeah. Excellent points, all of those. And I think all, kind of highlight some of the challenges and things that we should be thinking about at this, kind of earlier stage, right down the line. I know people are thinking about, so that's great. We had another question. This one was related to Billy's remarks about, when do you engage? When is the right time to engage? And, is it when people are most vulnerable or in a crisis point, or earlier, when people aren't in crisis and maybe more receptive? And how do you identify those points? And kind of what is the process, even from a research standpoint, that you go through to determine when the right point is? Also for an individual, right? And kind of not just on the whole. And so I'd be interested in hearing our discussant's thoughts on this, and any other panelists as well who may be off camera right now, but wanted to chime in at any time should feel free. Matt, go ahead.
Yeah, I mean, we've got decades of research on learning to guide us, and to use sort of common colloquial examples, it's like learning an instrument or learning a sport. You practice under cooler, calmer conditions. If you're shooting a free throw in basketball, you don't practice it during the game. You practice outside the game when and you get the skill down so that when you're in a high stress situation, you can perform it well. And the same is true here. To Billy's point, we don't want to teach people a skill or only intervene when people are under their highest level of risk. We want to develop that at other times and then work toward that. So we don't, a good thing is we don't have to start from zero here or square one. We've got decades of research on basic psychological science to build on and bring to bear to these approaches.
Great point, right? So while the approach, the technology may be new, what we know about human learning hasn't changed, right? It's just we're applying it in a different way. Exactly. Excellent point. Anyone else? Walter?
I'll just make a very small point, which is I think a lot of people, when they hear JITAIs, think the JITAI needs a specific adaptive intervention. JITAI is trying to do everything, right? It's both trying to figure out how to balance between states of vulnerability, states of receptivity. But a lot of the time you might have an intervention package with multiple intervention components that are all different JITAIs focused on different things. So you may have one that's focused on in states of vulnerability, high vulnerability, what do we do to help them? When we're looking at prevention, that might be a different JITAI component. And then how do we have another one that might be working on engagement? And so I think often when I see people try and do too much with one component, it's that they really want to build a package of multiple components, and that's an easier way to sort of think about it.
I would just correct one thing Walter said. I think when most people think of JITAIs, they think of Yoda or Obi-Wan Kenobi.
That's true. And if only
otherwise, I agree.
If only we could package them. I know. No, that's a great point. Well, and speaking of engagement, actually, I think with any digital intervention, right, or non-human driven intervention, engagement can be a challenge, right? What we see often is there's this engagement early on, right? And then there's either fatigue around engagement in the intervention, or there's just this drop off, right? That happens. And so with just-in-time adaptive interventions, what are your thoughts on where we are with sustained engagement with these when we're trying to, prevent suicide in the long term in any given individual? We want something that's going to last longer than a week or two in terms of engagement. So.
Well, I think that one of the findings that I believe is a theme that's come through in the literature is that having some kind of human touch in the intervention somewhere, and it doesn't need to be very heavy. So sometimes just the fact that a human was involved in your onboarding can actually be a factor in engagement ongoing. You can also have very light touch forms of human intervention, such as text-based interactions, things like that, that can really quite dramatically increase engagement across the usage. One of the things that fascinates me is that I've spent quite a few years being pretty skeptical of what we might achieve with chatbots, but of course the developments that are occurring in that field with large language models and the sophistication that they're bringing to that sort of technology, and the idea that people might, even for other purposes, be developing relationships with chatbots. It'll be very interesting to see what the capabilities of those very scalable technologies are to actually bring that human touch into the intervention so that there can be an enhancement in engagement.
Great points.
I see Billy's got a hand up.
Yeah. Billy, you want to go ahead?
Yeah, is it okay to chime in? I wasn't sure.
Yeah, please.
Go for it.
So I completely agree with Nick. The only thing I wanted to add is that, and this relates to one of the questions in the chat, one mistake that people make sometimes when they design a JITAI, they're thinking that they could pay participants for completing assessments that are being used to tailor and make decisions in real time. And that's a problem because, yes, it can increase engagement, obviously, if you pay people. Well, not always, but in many cases it does. But what it does is it increases the cost of the intervention. It means that when you roll out the intervention in the real world, you have to include these incentives in order to get people to engage and benefit from the intervention. So that makes the intervention more costly and less scalable. So that's just something to think about.
Yeah, definitely. Matt, did you have something?
Yeah, I think this is a huge issue, and it's an issue with, I think, virtually all smartphone app-based things, not just interventions, apps in general. We all use just a small handful, and then they shift over time in what we use and how engaged we are. So this is, big science and big business, figuring out how do you get people to engage in ways that are helpful and not harmful, and how do you sustain it over time. So we're not alone in trying to think this through and get it worked out, but it's going to be it's a huge piece of the puzzle.
Yeah. For sure. And Randy, I see your hand up.
Yes, the presenters are very civilized. We raise our hands. I think one of the other challenges, I think all these points are excellent. I think one of the other challenges is how could academic medicine keep pace with technology in a way in which we're not creating yesterday's interventions without optimizing what we could do. I mean, the most obvious candidate in the room is AI, of which we're developing tools that are clinician facing for all the appropriate caveats in terms of not wanting to have any iatrogenic effects. But the challenge, of course, is that by the time something is to form, we run the risk of it being dated by the time it's ready to be deployed in the context of an emergency. And I really think, there's obviously mechanisms through NIMH, including SBIR and others, but I think we really have to be careful if we're putting forth the energy to really rapidly improve detection. And I think we're not quite there, but, we're getting better. Eva and Matt and others' work has shown that. Eva's work is showing that we're able to deploy this in different types of places, which is really exciting. And I really worry that when it takes form, we're gonna be playing kind of Nintendo, which I know Matt understands, but we're really in this kind of advanced gaming world. And I think that this is a challenge that we think about a lot, but I don't really have a particularly good answer for.
Yeah, I was going to say, Randy, my Clippy-based intervention is just about ready for deployment. So
I love it. I
yeah,
love
just in
this.
time.
Yeah, it is a challenge, right? And I think it is true in a lot of tech areas. Do you know of any areas in healthcare and technology where somebody's doing a good job of addressing that even now? Outside of mental health even?
Well, I think it's rife with examples of it not being done well. I mean,
I know, I can think of
problem is
those.
that, you know, most of the digital health options out there that are available in the App Store or Google Play are without any empirical evidence, but their UX is to die for. And so I think that is kind of what we're up against.
Yeah.
I think it's a challenge, first of more of a public health kind of challenge of better educating consumers and providers about apps, but then also figuring out how we can iterate research quicker in a way that is still scientific, whether that's working with regulatory bodies to get things approved quicker, which I think everyone would agree would be great, but then also figuring out ways to have the apps that we use look better than just like a standard grade research app to at least get closer to approximating this final product. But I think it requires a lot of outside areas, you know, outside of just mental health to make that work.
Yeah, and of course, there's, you know, millions and millions of dollars going into monitoring people and intervening in terms of sales and marketing and trying to sell us the t-shirts and sneakers we want and so on. And it does generally a good job, at least in my case, but it's often wrong and totally misses. And that's a concern when your outcome is suicide or substance use or alcohol use and so on. So I think there are examples where it's well done, but given the stakes here, you know, we really want to make sure we get it right before we deploy. And as to Randy's point, it's got to be slick and shiny, but it's also got to be really science-based and accurate for us to feel ready to deploy it at a large scale.
And Walter, did you have something? I think
I was just, so my only addition on this one was, again, coming from the stats perspective, a lot of these, like Amazon, right? They can iterate on a weekly scale because they have thousands or hundreds of thousands of people who they're getting data points on in terms of these different factors. But for us, right, I agree with Randy that we might make a Nintendo in the era of, you know, Nintendo 64. That was my growing up. That was mine. But the biggest issue for us is also like if we want to iterate even at a remotely large scale, so 100 people in a given study to inform the next study, that iterative process is very slow still. And understanding how to iterate appropriately, I think, you know, as people build these JITAIs, one of the hardest things too is thinking about how to incorporate multiple components into a single intervention package. And I think that optimization phase is super important, but hard when you can only recruit, you know, 40 people per phase. It's not a lot of information. So I think that the scale issue becomes a huge one there.
Yeah, and speaking of things that are difficult to kind of move forward on quickly or iterate on quickly, you know, there's this kind of underlying interest, I guess, in really like personalized just-in-time adaptive interventions where, you know, they're really adapted to the individual, right, and responsive to the individual. And what are some of the challenges with that, and why haven't we been able to get there yet?
I think a big one is the statistical challenge of building person-specific models that tell us when this individual is at risk. Shirley Wang, researcher at Yale University, has a paper just getting ready to come out in Nature Mental Health on idiographic models, so using a person's own data to show when they're at risk, to predict when they're at risk, and then figuring out the topic of today's meeting, which intervention for that person at this time. It's several layers of nuance and of complexity. We're not yet good at knowing which people are at high risk. We're working on when those people are at risk, and then figuring out when this individual person is at risk and what's the right intervention is just several steps from where we are. So I think there's great promise here, but we're not yet approaching it in terms of the data, the accuracy of the data we have.
Yeah, and the only two things I'll add on this, one is just that the right intervention for that person may change over time. So not only is it that the intervention you want to provide for that person in the moment is hard to learn, but then that intervention, it may change after a month or so. And so I think especially with sequential, so I know a lot of these JITAIs, right, they're sequential in nature. A large headache is figuring out the right thing to do and also adapting within a person over time to their changes.
There's also a massive computer science challenge too, an engineering challenge. Like some of these things integrating wearables and GPS requires a lot of computational power in the moment on someone's phone. And some of that is happening, but it really is, this confluence of better understanding the mental health phenomenon, but also the statistics and the modeling, but then just literally computer science, battery technology, all of these things catching up to actually make it work in real time.
Well, and that issue interacts with another important one, which is, questions of privacy and security with data. Because one of the solutions to privacy and security is to do what's called edge computing, so to compute everything on device. Nothing goes to the cloud. That could have privacy implications. But of course, that requires a lot of computing power on device. Now, I will say I'm personally probably pretty bullish about what devices are going to be able to do on the edge. A lot of them are including incredibly sophisticated chips and technology that will allow that personalization to happen. But the other thing that I think is really fascinating about these questions that we're raising about personalization is that these are questions that working clinicians are trying to answer every day in their clinical work. Is this client at risk now? When should I pivot my strategy? It's just these questions are as old as clinical practice, but what we have is a new kind of data. And it's an exciting kind of data, but we need to really work how to bring these questions to bear to that fundamental clinical question, because clinicians work with individuals and they are always asking the question about this individual.
Exactly. Yeah. Wonderful. Excellent discussion, you guys. I think that's a great place to wrap up. We're at 3 o'clock. And I just wanted to, again, thank everyone for their wonderful presentations today, excellent discussions, and just overall enthusiasm for this area of research. It's very exciting, and I'm excited to see where it goes next.
Thank you, Mary, Stephen, and NIMH.
All right. Thank you all. Take care.